purpose of this video is to review policy for Raleigh General Hospital on falls prevention. The purpose of this policy is to reduce the potential for a patient injury from a fall. The fall prevention policy and procedure supports the Everyone Lessening Falls Fall Prevention Plan and denotes processes assigned to various staff and physicians. The learning objectives of this video include policy overview, review of the fall packet, review of the fall risk assessment tools, and review of red flag placement. Definitions for the types of falls include a fall, a loss of upright position that results in landing on the floor, ground, or an object or furniture. Sudden, uncontrolled, unintentional downward displacement of the body to the ground or other object. Excluding falls resulting from violent blows or other purposeful actions, assaults. A near fall is a sudden loss of balance that does not result in fall or other injury. This can include a person who slips, stumbles, or trips but is able to regain control prior to falling. An unwitnessed fall. This is when a patient is found on the floor and neither the patient nor anyone else knows how he or she got there. Fall risk factors are divided into two categories. Intrinsic risk factors. This includes factors that address a person's physiological condition. Example, history of falls, incontinence, mobility, dizziness, age, osteoporosis, overall poor health, etc. Extrinsic risk factors includes factors that address the physical environment. Examples could be a wet floor, cluttered room, poor lighting, inadequate handrail support, inappropriate or lack of footwear, a low toilet seat, wheels on beds or chairs, restraints, prolonged length of stay, unsteady IV poles, broken equipment, or beds left in high position. Adult inpatients or outpatients will be assessed and reassessed using the Morse fall scale to identify those who are at risk for falling. Intervals for assessment and reassessment include on admission and each shift, with a change in condition immediately post-fall, or with a change in the level of care. The Morse fall scale is scored as follows. The history of falling. This is scored as 25 if the patient has fallen during the present hospital admission or if there was an immediate history of physiological falls, such as from seizures or an impaired gait prior to admission. If the patient has not fallen, the score is a 0. If the patient falls for the first time or has a near fall, then his or her score immediately increases by 25 and the patient is considered a high risk for fall. Secondary diagnosis. This is scored as 15 if more than one medical diagnosis is listed on the patient's chart. If not, score is 0. Ambulatory aid. This is scored as 0 if the patient walks without a walking aid, even if assisted by a nurse, uses a wheelchair, or is on bed rest and does not get out of bed at all. If the patient uses crutches, a cane or walker, this variable scores 15. If the patient ambulates, clutching onto the furniture for support, score this variable 30. IV or IV access. This is scored as 20 if the patient has an intravenous apparatus or a saline heparin lock inserted. If not, score 0. Gait. The characteristics of the three types of gaits are evident regardless of the type of physical disability or underlying cause. A normal gait is characterized by the patient walking with head erect, arms swinging freely at the side, and striding without hesitation. This gait scores a 0. With a weak gait, the score is 10. The patient is stooped but is able to lift the head while walking without losing balance. If support from furniture is required, this is with a featherweight touch, almost for reassurance, rather than grabbing to remain upright. Steps are short and the patient may shuffle. With an impaired gait, the score is 20. The patient may have a difficulty rising from the chair, attempting to get up by pushing on the arms of the chair and or bouncing. The patient's head is down, he or she may watch the ground. Because the patient's balance is poor, the patient grasps onto the furniture, a support person, or a walking aid for support and cannot walk without this assistance. If the patient is in a wheelchair, the patient is scored according to the gait he or she used when transferring from the wheelchair to the bed. Mental status. When using the scale, mental status is measured by checking the patient's own self-assessment of his or her own ability to ambulate. Ask the patient, "Are you able to go to the bathroom alone, or do you need assistance?" If the patient's reply, judging his or her own ability, is consistent with the activity order on the medical record, the patient is rated as normal and scored a 0. If the patient's response is not consistent with the activity order, or if the patient's response is unrealistic, then the patient is considered to overestimate his or her own abilities to be forgetful of limitations and is scored as 15. All admitted patients are implemented a standard patient safety for all hospitalized patients. This includes reducing extrinsic risk factors and universal precautions, environmental interventions, floor-level night lights, bed in lowest position, height-appropriate toilet, no full-length bed rails, no trip hazards, items within patient's reach, call light within reach, equipment and furniture wheels locked, sturdy furniture and assist devices indicated available and within reach, floors dry, bathroom grab bars in place and sturdy, skid proofing intact, hallways free of clutter and non-obstructed by carts or equipment, handrails sturdy, cords contained and managed to prevent entanglement with patient extremities. The interventions for high-risk fall patients include those same universal precautions, plus a yellow icon in place for high-risk patients with Morse fall scores greater than 45. This includes yellow armband on the same arm as the ID band, a yellow magnet on the doorframe, non-skid booties placed on patient, and a falling star sign over the head of the bed. Other high-risk fall prevention interventions include hourly rounds with the 4 Ps: potty, pain, positioning, personal needs, or a toileting schedule developed and someone to remain with the patient while toileting. Staff assistance required to get out of bed, transfer, or ambulate. Non-slip booties or rubber-soled shoes at all times when up. Also, consider hip protector, elbow, or knee pads. If the patient is high risk with forgetfulness, confusion, or overestimates ability, add bed alarms and chair alarms. Room location to promote observation or staff monitoring. Low bed at all times. A sitter or a family monitor. ELF signs should be used for the patients at most risk of moderate to serious injury from a fall. This includes A. Age or frailty, 85 years or older. B. Bones, bone cancer, osteoporosis, fractures. C. Coagulation, bleeding disorders, or on anticoagulants. S. Surgery, post-surgical patients. These patients are to have a yellow ELF sign in their doorway facing outward. Patient education is provided to the medium and high-risk fall patient and family. This includes orientation to the room, pointing out the safety fall prevention in the environment. Verbally informing the patient and family of fall prevention interventions. Providing a brochure, if applicable, to reinforce education. The use of the call light. Appropriate footwear. Posture techniques to ensure balance. Use of bed controls. Use of assistive devices. Bed techniques and identification of strong side when moving. Ask the patient to perform teach back and demonstrate back as a method to reinforce education and build confidence and competence with fall prevention techniques. Re-education should be as indicated. Place signage for visual reminders. A falling star over head of patient's bed. The following interventions are taken immediately after a fall to determine the causes of and injuries sustained from the fall. The patient is assessed and findings are documented on the patient post-fall assessment form retained in the medical record. Patient's mental status. Vital signs. If blood pressure is stable and no obvious signs of injury are noted, the patient may be moved. If vital signs are unstable or there are obvious injuries, the physician is notified immediately. Check blood sugar. Check pulse ox. Family members, nursing supervisor, and physician are notified. Description of the fall and injuries noted from the fall. Determine causes of the fall, including equipment that was in use at the time of fall. Completion of the post-fall analysis debriefing form. X-rays ordered per physician. A yellow fall risk magnet is placed on the room door if it had not been previously done. Also, a yellow fall risk bracelet is placed on the patient, and the high-risk fall intervention plan is initiated. Document the Morse scale and high-risk screening post-fall occurrence for adults. Non-clinical employees, volunteers responding to a fall will not move or lift an individual, but will call immediately for clinical assistance. An occurrence report is completed for each fall and near fall. This communication also includes shift report, the the patient's last fall risk assessment score, interventions implemented, patient's response to fall prevention, changes in the patient's status, treatment, procedures, medications that have changed, the fall risk level, and any special needs relating the patient's safety will be communicated to the oncoming nurse. The receiving nurse holds the responsibility to communicate patient needs and intervention expectations to the care team. This communication also includes shift report, the patient's last fall risk assessment score, interventions implemented, patient's response to fall prevention, changes in the patient's status, treatment, procedures, medications that have changed. Patients will be cared for in a safe environment. Fall prevention procedures are based on the assessment of the patient, determination of the patient's risk for fall, and implementation of interventions that reduce the intrinsic and extrinsic fall risks identified. Patients will be cared for in a safe environment. Fall prevention procedures are based on the assessment of the patient, determination of the patient's risk for fall, and implementation of interventions that reduce the intrinsic and extrinsic fall risks identified. Procedures for adult and pediatric fall prevention in the acute care or the outpatient